celui-là,
Ok.
ensuite c'est moi sur celui-là,
Ok.
et après c'est celui-là.
Donc moi je lance mon enregistrement.
Oui, oui. Tu es où toi? C'est celui-là? Alors je sais pas pourquoi il me dit ça à chaque fois, mais bon.
Là ça sort.
Regarde si tu peux passer tes slides. Please. Thank you, please. We have to begin because we have not a long time for the lunch. So if you can go back to your seat, and we are going to have a lot of discussion this afternoon and during lunch and after, during the dinner. So the second part of this morning, we are going to talk about the famous Delphi method for equinovarus foot. First of all, I would like to thank all the experts who have worked a lot on these questionnaires. And it was really, really, really nice from you to feel and spend all the time with all the problems we had. So thank you so much. All the experts have filled the Delphis free yesterday by night, and you will have the Delphis free for the elbow during lunch. Only 10 questions. The main point is that the expert has to respond before the community, and after we will compare. Okay? So everyone has his, device, if you are surgeon or physician. Okay? First of all, I asked to the Lille team, and Etienne Allart was the lead for this project, to make the literature review of the medico-surgical management of spastic equinovarus foot. Okay, so if we are going very quickly, we will have time to continue the discussion about equinovarus foot and the treatment, and Bertrand can ask his question if you want.
So thank you, François. And we welcome Etienne Allart from Lille to present us the bibliography on the literature of the Delphi-oriented review. So thank you, Etienne, for coming from Lille.
Thank you. So François has given me the impossible mission to make the review on the equinovarus deformity and present it in 20 minutes. So surely it will be non-exhaustive and oriented to support the discussion we will have in the Delphi process. So we'll consider a few elements on the patient selection, on the different steps on the way to surgery, and focusing particularly on the assessments, and finally we will review all the different kind of procedures, and we'll see the outcomes of these procedures. First, surgery is a technical procedure, and so it is adapted for given neuromotor deficiencies. And when we consider muscle overactivity, spasticity is often put at the forefront, but spasticity is not the only form of overactivity we had in the foot deformities. But the patient is not limited to his lower limb, and we had to consider all other kinds of parameters, such as the disease and patient history, comorbidities, the function, the activity function, and some other psychological parameters. And so we'll see what the literature tells about that. I said that spasticity is not the only thing. To my mind, spastic co-contraction in equinovarus foot is another important obstacle to movement, and that have been showed in the PhD thesis by Maria Concheta Vinti. You can see here the level of spastic co-contraction here in the soleus, in the gastroc here, during the swing phase of gait, not only during analytic movement of the ankle. And that's very important because the pathophysiology of these different kinds of hypertonia are not the same, and Thierry will talk about that this afternoon, and it leads to different response to treatments depending on the mechanism of action of this response, and particularly when we compare nerve procedures and tendon procedures. That being said, here is the most common way to analyze factors responsible for equinovarus deformity. Some factors create a resistance to movements, so calf muscle overactivity and not only spasticity, calf muscle contractures or its less severe expression and unaltered elasticity. At the opposite, the engine is weak, and this the weakness of dorsiflexors are reinforced by spastic contraction here. And last, we have some muscle imbalance between TP, EHL, TA, etc., and fibraris muscles. Concerning the type of patients in the literature, we have mainly hemiplegic patients after brain injury and particularly after stroke. But there are still some questions that the decision process is probably not the same in fixed or progressive diseases, or in the case of unilateral and bilateral involvement. No effect of age, sex, and the time since the lesion have been shown in this study by Namri, and there's still a debate on the moment we have to operate the patient. Is there a minimum delay to operate the patient? Some authors recommend a minimum delay to let the initial recovery, the maximum recovery, and so another thing that we have to operate when it's necessary, and particularly when the surgery is the only way to improve the patient. The most common reason to propose a surgical treatment in the literature is to counteract the ineffectiveness of conservative treatments, but also to search for a long-lasting solution to avoid bond or to avoid orthosis. And it could also have a medico-economical interest for the healthcare system, for example, here in this study in the US, but also for the patient, like in Belgium, or where the patient have to pay for bond and not for surgery. One comorbidity is often put at the forefront is the poor vascularization, particularly in vascular patients, but with no consensus with for the consequences of the presence of this comorbidity. And finally, we had no clear idea in the literature on all these parameters. Let's now move to the assessments. The way to clinically assess the patient is now widely consensual. It begins by the patient or the caregiver needs and expectation, which are translated by the physical examination of the real function. Okay, you have troubles when walking, so you can walk. We can see kinematic anomalies, etc. And then analyze the three components of the neuromotor triads. I go fast on this point to determine therapeutical targets. Therapeutical targets are not therapeutical goals. The functional assessment is also important, not only what the patient can do in your room, in your consultation room, but what he really does in the real life. And there is sometimes a wide gaps between these two dimensions, and it's important to consider when we set goals. And finally, who to take part in the decision? A large majority of physicians assess their patient in a multidisciplinary team setting, but some other authors proposed the possibility to a remote consultation, particularly using the data of quantitative gait analysis. And some of the team use telemedicine as a first-line assessment, for example, in France, in Toulouse or in Bordeaux, to avoid highly disabled patients to come and to make far this distance to come to your consultation room, and to benefit of the effective attendance of the caregivers of nursing home, for example. An important question, we already talked about it. Can I rely only on my clinical data, or is there a need to go further than clinical examination? The answer in the literature is a big yes. To provide a better targeting of surgical procedure in two ways: treat or not a muscle and avoid the over-treatment, and choose the right type of procedure for a given muscle depending on the type of the efficiency. So we have two different strategies: the lab gait analysis and particularly dynamic EMG, and diagnostic nerve blocks. Marianne Keenan already talked about this study. When you took an experimented surgeon and an experimented surgeon, it's not easy in English, who examined the same sets of patients, formulated a plan, and then you give them the data of gait analysis, and they can adjust their plan. So high percentage of change, high increasing in the inter-evaluator agreement, and not just a move from the unexperimented surgeon to the experimental surgeon, but a common move to a common surgical plan. Interestingly, these findings from a study by Jacqueline Perry is that the pattern of activity is not influenced by the different procedure you can perform on a tendon. So if you have a muscle that is contracted in a given phase of the gait cycle after surgery, it will be the same. So, for example, if you intend to transfer the tibialis posterior to the dorsal midfoot, and if the tibialis posterior is active during swing phase, it's a mean to predict the efficacy of your transfer, keeping in mind that EMG activation is not equal to mechanical activation of a muscle. But with EMG, you have no clear idea of if your muscle is hypertonic only, or if it is contractured, and it requires cost. It requires more money and time. So the other possibilities to perform nerve blocks to differentiate hypertonia from contracture, to identify the muscle nerve, and to study the effect, either the positive effect and the negative effect of reducing the hypertonia on the function. It can be done over the trunk of or selectively, and Thierry's team has proved that the result of the block predict the result of tibial nerve neurotomy. Contrary to a widespread false belief, nerve blocks are safe, and we with the French PMNR Society, we recently published practical guidelines dealing with the security of the blocks and also other things. And if you are less than 10 millimeters of lidocaine, the block is totally safe. You cannot block all nerves, but if you want, you can also make some intramuscular blocks with lidocaine. So these two techniques are not conflicting, but are complementary, and they are used depending on the access to the technology and the habits of the physicians. Smart goal setting are now the rule in neuro-orthopedics, and Thierry's team just published the first study exploring goal attainment with the gas, and that demonstrated, in addition to well-known effect we will see on spasticity, passive motion, etc., a high level of personal goal attainment after neuro-orthopedic surgery. So let's move now to the treatments. For the treatments principle, we already seen some of these procedures in the previous talks. To correct the equinus deformity, you can make a tibial nerve neurotomy, Achilles-tendon, with different techniques. Gastrocnemius aponeurotomy, with still a question on the table. When you have a muscle that is spastic and contractured, is there a need to treat both spasticity and contracture, doing a neurotomy and a tunnel lengthening? Or is there only a need to lengthen the muscle because lengthening a muscle modifies the threshold of the neuromuscular spindle? So we will have to discuss that during the Delphi discussion. To correct the varus deformity, you can act on the TA, the TP, the EHL. Instance to lengthen the triceps, and in some case, some rare case, to perform articular or bone procedures. Next, to improve active plantar flexion, the first thing to do is to correct equinus instance to increase the peak plantar flexion moment in swing phase, and then you can also, as presented by Marianne Kinan, transfer the FDL of the FHL to os calcis. And to improve active dorsiflexion, the first and probably main thing to do is to correct the equinus, the spasticity of contracture of the triceps, and then transfer eventually the TP, the FHL or the EHL to the mid dorsum, and think about the preventive or curative treatment of claw toe. Post-op care rules are relatively consensual for neurotomy and arthrodesis. They are more variable for tendon procedures, with a duration of casting of 4 to 6 weeks, even 10 weeks in a study. A large majority of authorities on immediate complete weight bearing. And finally, some recommend the transitory use of an FO after cast removal, particularly when there are transfer of muscle to the dorsal midfoot. So let's finish by an overview of the efficacy of this treatment, trying to following the ICF framework. So for nerve procedure, we retrieve 17 studies, mainly in France and Belgium. One was an RCT comparing bone to tibial nerve pneumotomy, relatively small samples. Quite a long-term follow-up up to 2 years in prospective studies. That is quite interesting. And the amount of resection of the fascicle or the branch, the motor branch to muscle varied from 50 to 90%. Is mainly on the basis of the team or the surgeon experience, and not very on the basis of physiological data. So neurotomy hugely decreased the spasticity. As you can see here, it's relatively small. It improved passive range of motion, even if some authors have described some contractures appearing after a tibial nerve neurotomy. It sometimes improved dorsiflexor strength. It's often transiently weak the plantar flexors, and this has been explained by EMG data because of the transient decrease of the neuromotor numbers after neurotomy. The foot, the position is clearly improved, particularly in stance, and there's an inconstant and relatively low level improvement of temporal spatial gait parameters. A decrease in A4Us, and finally a slight improvement in walking and balance capacity. Very few data on participation, and when it's assessed, a high level of satisfaction in patients with a relatively low rate of side effects, and no recurrent described in this particular indication of tibial nerve neurotomy for the spastic equinovarus foot. Next, the tendon procedures. We retrieve 12 studies. In red, you have the studies aiming at correcting equinovarus, particularly in stance. In brown, the correction of the foot drop by transfers, and in blue, techniques to improve plantar flexions. The techniques are quite different, and their associations are also very different, so it's difficult to compare the studies. But like for tibial nerve neurotomy, we found an improvement of foot positioning. For the studies aiming at correct the foot drop, an improvement in swing phase, as we told, essentially by a tenodesosis effect and not by an active effect of the transplant with no flat foot. An inconstant effect on gait, a reduced use of A4, and a slight improvement of walking capacities. A few words on studies comparing some techniques. The first one compared EHL transfer and splat for the varus deformity and found some similar results. The second one found that the anterior FDL or FHL transfer was superior to the transfer of the whole tibialis anterior in the varus deformity. And finally, a study by Maria and Kinan found that there is an additive effect to perform FHL and FDL transfer towards calcis with a splat comparing to a splat alone. 5 studies used both nerve and tendon procedures and found globally the same trends. So we can conclude that both nerve and tendon procedures are efficient in treating the equinovarus foot deformity, but they are, if they are adequately indicated after a careful assessment, including complementary assessment like blocks or EMG or gait analysis, and with appropriated goals. And before moving to the Delphi process, I would like to recall that before being a questionnaire, a quite long questionnaire, or very long questionnaire, Delphi was a famous place in Greece where we can find the Pitya, who was consulted about very important decisions, and it was considered by Greece by the center of the world. So here we have in this room lots of famous Pityas. Here is François, the chief of the Pityas. And I'm sure that the oracle will be great. And Versailles is probably not the center of the world, but it's the center of the neuro-orthopedic worlds, and that's very exciting. Thank you.